Thank you all for being with us today. Jay Ziabart, nutritionist and health educator, and I'm Megan Mesher-Cox. We host this disease prevention and reversal summit and hope to be able to provide more information out there. So good information that's really evidence-based healthcare information and truly lifestyle medicine. Okay, so next up we have Dr. Kyle Stevens. Great, he's on with us. And please start to share your screen whenever you're ready. So Dr. Stevens has a successful family medicine practice in Ventura. Can we hear you?
Can you hear me? Hello.
We can hear you, we can see you. Okay.
Good morning, everyone.
Wonderful. So we're going to talk about secondary prevention cancer screening, and I'll hand it right over.
Hello, everyone. That was a great lecture by Dr. Wally. As a father of a 5-year-old, you know, it can be difficult with trying to get kids to eat what we want them to be eating. But we found that the earlier we started, we kind of started right out the gate with our 5-year-old, and it was really helpful. Just introducing foods that were healthy right from the beginning. And they only know what you bring to the table, right? They don't until you start taking them to McDonald's. They don't even know that exists. So it's a fun thing to experiment with, trying to get kids to eat a little bit better. So my name is Kyle Stevens. I'm a doctor in a family doc in Ventura. And so I'm going to talk a little bit about cancer screening today, and talk a little bit about secondary prevention and what that means, and dive into this. So let me see here. How do we got this set up? All right. So one of my favorite quotes is a Benjamin Franklin quote: "An ounce of prevention is worth a pound of cure," and that's what we're going to be chatting about a little bit today. So there's 3 types of prevention when we kind of look at the world of preventative medicine. And I wanted to just kind of dive into these levels real quick. I think it's an important background for this discussion. First is primary prevention. And this is the type of prevention that is preventing disease or injury before it occurs. And the examples are diet, exercise, seat belts. So the stuff that Jay is doing, and the things that we're talking about in this forum with diet is a form of primary prevention. We're trying to prevent the diseases from actually manifesting in the body. And there's a lot of obviously good work that needs to be done there, and this is the basis of our good health. The next level of prevention is secondary prevention, and this is trying to reduce the impact of disease or injury that's already present. And this is where screenings come in, right? This is where mammograms for breast cancer screening, and colonoscopies for colon cancer screening, and pap smears for cervical screening comes in. This is also where medications come in. So when we recommend statin medications to lower cholesterol or cardiovascular risk, this is a type of secondary prevention. There's disease there, and we are trying to do something to prevent it from getting worse. And then the third type of prevention is tertiary prevention, and this is reducing the impact of a chronic disease or injury. A good example of this is if somebody has a stroke or has a heart attack or has COPD, we put them into some rehab scenarios: stroke rehab and pulmonary rehab and cardiac rehab. And this is trying to reduce the impact of this disease that's already present in the person's life. Another example of this is support groups. So AA for alcoholics is another example of tertiary prevention. So next, I want to talk about the difference between a screening test and a diagnostic test. A screening test is a test that is done when you have no symptoms whatsoever. It is done early. It is a test to detect early disease, I should say, before it has become symptomatic. We are doing a screening test on someone when you're healthy, without particular complaints about the area in question, but who may have an underlying small cancer or a precancer. So patients with a lump in their breast, with a weird looking mole on their skin, or the inability to urinate, this is not screening if we're going to do any testing on this particular person. These are diagnostic evaluations. So there's a difference here between a screening test and a diagnostic test. And so why do we do this? Why do we screen healthy people? Why don't we just leave healthy people alone? And the reason is because the majority of cancers are easier to treat when they're caught early. Patients usually have better outcomes. Sometimes we can avoid chemotherapy. The surgeries can be smaller. And sometimes we can even catch things before it turns into cancer. And so this is the reason that we try and do these screening prevention tests. So let's screen everyone all the time. If it's so great, prevents bad disease, let's do it. Let's just screen everybody, do it all the time. Well, if you've ever interacted with the healthcare system, we know that this is a little bit problematic for a few different reasons. And so I want to talk a little bit about a couple of those. Tests can be invasive. Could you imagine getting a colonoscopy every year? Some of these screening tests have risks involved, and at some point, the potential risks of a test are outweighed. The potential benefits of a test are outweighed by its risks. And tests can be wrong. In this era of COVID, we know what the term is for a false positive. We're kind of more familiar with that than ever. But a false positive cancer screening test usually means that we need to do a more invasive follow-up test to determine whether the screening test was actually correct. For example, we know that doing frequent mammograms on younger women often leads to higher false positive rates, which means lots of women would get a breast biopsy that is negative or normal. This is painful, stressful, expensive over time. And the doctors and the scientists are constantly studying screening tests to find the right test, asking when is the right time to start testing a person, what is the right interval, and when is the right time to stop testing in order to help the most people and avoid the most amount of harm. Another reason why we're not just doing this all the time is that tests can be expensive. Tests take time, both patients' time and doctors' time. So we want it to be a worthwhile thing to be doing. And it can be stressful, like I kind of mentioned earlier before. A perfect screening test is one that catches only people who have the disease. It weeds out the people who don't have the disease. It is cheap, quick, easy, is easily tolerated, and improves the patient's outcomes, meaning that the test allows the patient to live longer with a better quality of life because we've caught the disease process early. So how often should we screen and for what? So this is going to be kind of the bulk of what I'm going to get into next. It isn't quite as clear cut as you would imagine because there are many organizations that make recommendations on cancer screening. I've listed a couple of them here: the American Cancer Society, ACOG, which is the American College of Obstetricians and Gynecologists, AAFP, which is the American Academy of Family Physicians, the United States Preventative Task Force. For the most part, these different groups are in agreement as to what we should be screening for: cervical cancer, breast cancer, colon cancer. The main differences that we see between the groups are often at what age to start screening and how often to screen. For my practice, I follow the recommendations by the American Academy of Family Physicians and their guidelines, and those usually mirror the United States Preventative Services Task Force recommendations. That task force is a national group of epidemiologists and primary care doctors who are looking at the pros and cons of screening tests and are making general recommendations. One thing to keep in mind is that these recommendations change over time as more data and evidence emerges. So what was true for a screening test in 1990 is different today. And it's not because we don't care about that type of cancer anymore, but because we know more about it. So some of you may be surprised when I go through some of the recommendations and guidelines because they might be a little bit different than what you've had done for yourself over the years. I'm going to break down some of the recommended screening tests, but there's an important caveat. This should not replace any conversation with your own primary care doctor. Your family history matters, your other medical problems matter. These are generalized guidelines, but you are an individual, and together you and your primary care doctor need to discuss what makes the most sense for you. I'm going to avoid listing all the different guidelines from all the different groups and get really confusing. I'm going to stick with the AAFP and the United States Preventative Task Force recommendations. But do recognize that there are other recommendations and guidelines, and potentially some of your physicians are looking at a different set of guidelines than what I'm going to talk about today. And I'm not going to talk about every cancer screening test out there. I'm going to hit a couple of the big ones. I'm not talking about lung cancer screening, for instance. So The first one we're going to talk about is skin cancer screening. And this is a good illustration of kind of the differences in guidelines. The official recommendation from the United States Preventative Services Task Force and AFP is skin cancer screening is uncertain. We don't actually know. The AFP states that there is not enough evidence for, quote, regular people with no symptoms, no concerning moles or spots to go see their doctor for an in-person skin exam to screen for skin cancer. Now, the American Academy of Dermatologists, on the other hand, think skin cancer screening is so important, they have a nationwide program where they offer skin cancer screening tests for free. And this is why we need to have conversations with patients as doctors, and you as patients need to have conversations with us. If you're a fair-skinned, tanning bed veteran with a family history of melanoma, probably going to be recommending that you get your skin looked at every year. But I might not be recommending that for everybody. Cervical cancer screening. This is one of my favorite ones because of some of the history that's happened over the last couple of decades. Cervical cancer screening is also known as the Pap smear, and the recommendations have changed a lot in the last couple of decades because of the introduction of the Gardasil or HPV vaccine. We now know that cervical cancer is caused by HPV, the human papillomavirus, and it was FDA approved in 2006, I believe, and since then, cervical cancer, as more people have been getting this vaccine, cervical cancer has become less prevalent, and therefore the screening recommendations have changed over time. At this point in time, Pap smears are recommended to start at age 21, and they're to be done every 3 years for women when they're in their 20s, and then at age 30, if you do a Pap smear and you do an HPV test along with the Pap smear, which most of us are all doing at this point, it's a Pap smear every 5 years, as long as it continues to be negative and doesn't have anything that's concerning. Oh, sorry. Women who have had a hysterectomy for reasons that are not related to cancer, the recommendation is actually to stop getting Pap smears. It's not that we don't know, it's not that it's uncertain, it's that you don't need Pap smears. And the same recommendation holds true for women over 65, is that you no longer need a Pap smear. Now, you do need to keep in mind here that a Pap smear is a very specific test. It's looking for cervical cancer. There might be another reason that your doctor is recommending to do a vaginal exam or a pelvic exam on a regular basis. So that would be a discussion that you want to have with your doctor about that. Okay, colon cancer screening. So the current AAFP recommendation for colon cancer screening is to start at age 50. I want it to be noted at least that the United States Preventative Task Force last year started recommending that colon cancer screening start at 45. The AFP disagrees with this recommendation at the moment, so they're still saying 50, but there might be a switch to this where we start screening people for colon cancer earlier at 55. After age 75, that decision to do colon cancer screening becomes individualized. So that's a conversation once again with your doctor. I'm 75, I'm 76, I'm due potentially for a colon cancer screen. Should we do it? How should we go about it? What's your life expectancy? There's some questions like that get taken into account. And then to do colon cancer screening, we have a few different options available. So we all have heard about a colonoscopy, but that's not the only thing available. A colonoscopy, if everything looks good, we do those every 10 years. But now there's some good newer technology that's out there that allows us to do colon cancer screening with an at-home stool test every year. And that's a yearly thing that you would do. And some people do a colonoscopy at 50, and then at 60, they decide that for the rest of their screening life, they're going to do at-home stool tests. That's a reasonable thing to consider to do. And there's also a DNA test, a little bit more expensive, not always covered by insurance, but that's also a poop test, and that's done every 3 years. Prostate cancer screening. So prostate cancer screening was a whole week's worth of lectures at medical school. It's complicated, and the groups can really differ in their recommendations for this. one of the reasons for this is that prostate cancer is very common, but it's not often deadly. Many men with prostate cancer would never even know they have the disease, and they'll typically die of something else. But the treatment of prostate cancer, if we do find it, can be really invasive with lots of bad side effects. Early detection and treatment is not as clear cut in prostate cancer as it is in some of the other ones that I was speaking about earlier. And essentially, we don't know if we're causing more harm or more good on a population level by screening for prostate cancer. The screening test that I'm referring to when we're talking about prostate cancer screening is a PSA, or a prostate-specific antigen, and it's a simple blood test. In most organizations, the rectal exam is not considered an adequate screening test. The United States Preventative Task Force and AFP don't agree on the PSA. For men ages 55 to 69, one group says talk to your doctor first and decide after you've considered the risks and benefits. The other group much more clearly states that they do not recommend it, but they also encourage men to discuss the pros and cons with their doctor. Both groups say stop screening at 70, and how often to screen, some say yearly, some say every other year. Now, if there's any urologists listening to this talk, they're probably freaking out a little bit. The American Urology Association absolutely recommends PSA screening. So you can see this can be a little bit tricky. But oftentimes what I've experienced is men kind of know what they want. They say, you know, I have a friend that had prostate cancer, I had a relative that had prostate cancer. I want to do whatever we need to do to be looking for this. And then we'll have a little bit of an individualized discussion about what we want to do and how we want to approach it. All right, and breast cancer screening. So this is the last one that I'm going to talk about, and there's a few differences in recommendations on this one as well. The AFP and the United States Preventative Task Force recommend screening at 50 with a mammogram every 2 years. And for women ages 75 and older, we don't entirely know. So that, once again, that's a little bit of a discussion with your doctor about what you guys want to do about screening for breast cancer after age 75. And for women ages 40 to 49, you could start screening, but it's a risk-benefit discussion with your doctor once again. Starting in your 40s decreases your chance of death from breast cancer, but the false positive rate jumps up really high. And you might need to get a breast biopsy to prove something is benign. And then you might need to get another mammogram in 6 months, and then an ultrasound. All this for something that isn't or will never become cancerous. Now, the American College of OB-GYNs recommends starting at age 40 and screening every 1 to 2 years. And the American Cancer Society recommends starting at 75. If you're kind of all over the place with this, I'm explaining it this way because I want you to understand that there is some differences in the recommendations. We don't know the perfect age to start. We know the more you screen, the earlier you start, the higher risk of false positives and potential needs for further testing and maybe even biopsies. And I usually have a discussion with women about, you know, what's your family history and what's your level of anxiety about this? Is this something that's going to keep you up at night and you're going to be worried about it? And maybe we make a little bit different of an individualized decision for you versus somebody said, I don't have any family history. I don't really have any concerns. Let's do it, you know, start at 50 and do it every couple of years, which would be a perfectly fine thing to do as well. Now, the one other thing I would like to say at the end for this is that for breast cancer screening, average risk women, we only currently recommend mammograms. A breast exam at your doctor's office isn't sufficient. An ultrasound, MRI, thermogram, those are not screening breast cancer modalities. And then I'll kind of finish up with a question about whether or not we should stop cancer screening because of COVID. We've been in this weird place the last couple of years with telehealth visits and Zoom visits and some ability to come into the office for periods of times, and then other periods like right now where I'm not seeing very many people in the office. But should we stop our cancer screening because of this? We really shouldn't. We really should be try and stick to a screening plan for our patients. But one of the things I hope to have highlighted here is that some of these screening things aren't as often as you might have thought. So you might think, oh man, I really need to get in and get that done or this done. on. And it turns out that actually you might have a year or two before that's actually due for you to get screened for whatever the particular test is that you might have some concerns about. I had some quiz questions, Megan, but I think I'm running a little bit over, so I was gonna turn it over for questions and answers instead of that.
Well, your quiz questions might actually be wonderful.
Okay, we can do
I
that.
have questions here, but yeah, let's start with your quiz.
Okay, so which of the following is an example of secondary prevention? And you guys can, I don't know, type it into the chat or raise your hands when I say it or however you want to do it. Getting a mammogram, getting a colonoscopy, taking a statin medication, or D, all of the above. Survey says it is D, all of the above. Okay, so a 55-year-old woman finds a breast lump while showering. She talks with her doctor, who does an exam and recommends a mammogram. This mammogram is best described as A, routine, B, a screening mammogram, C, a diagnostic mammogram, or D, all of the above. I can't really see much, Megan. Are people saying anything? Do they? Yeah, maybe.
Oh,
C,
yeah.
diagnostic. So we know that there's something there. We're not screening. We're trying to figure out what the heck is that? Is that okay to be there? Is that something we need to be concerned about? So we're doing a diagnostic test. And then what is an example of primary prevention? A, getting COVID. B, getting a colonoscopy. C, getting a COVID vaccine. D, all of the above, or E, none of the above. So that one is, as my 5-year-old says, drum roll please, C, getting a COVID vaccine. We're trying to prevent you from actually getting the disease, and that's what immunizations fall into the category of primary prevention. Couple more. What age is it recommended we stop screening for cervical cancer? 75, 65, 80, never stop, never start. The answer is B, 65. Which of the following is an example of tertiary prevention? Going to an AA meeting, taking a statin, wearing your seatbelt, getting a mammogram. Tertiary prevention is the one for chronic diseases, if you remember, and that's trying to lessen the effects of the actual disease or injury. And so going to AA meetings would be an example of that. I think I have one more. This one I didn't cover, but I wanted to make sure that I at least gave a sentence to it. So I'm going to ask it within a quiz question. Which age do we start screening for ovarian cancer? 21, 50, 65. Ovarian cancer screening is not recommended. Answer to that one is D. Ovarian cancer screening is not recommended. And for some people that might be a little bit of a surprise. I think that I definitely have had many female patients come and assume that we're doing a pelvic exam, looking for ovarian cancer or looking to screen for ovarian cancer. And we have found that a pelvic exam or a bimanual exam doesn't actually do a good job of screening for ovarian cancer. So there is not any recommendations currently to screen for ovarian cancer because we just aren't good enough at sort of meeting the requirements that I talked about earlier for there to be a good screening test. And so maybe in the future we will find something that's a good screening test for ovarian cancer, but at the moment we do not have any such thing. That is all I got, Megan.
Thank you so very much. So I have one question and then we'll let you go. That was awesome. Thank you so much, Dr. Stevens.
You're welcome.
So colon cancer screening, you mentioned that there has been a recommendation by some task forces, not all, to start at 45. Can you tell us your thoughts? Why do you think that the earlier age is now recommended by that task force instead of?
Yeah, so it's interesting. The United States Preventative Task Force has just kind of looked at data and said, okay, we're starting to see colon cancer earlier, so we need to, based on the data, we need to move up the screening age in order to catch these people sooner, because the disease becomes, from their mind and looking at the data, too advanced at 50. So if we check at 50 and we're like, oh crud, this is actually much worse and it's going to be much harder to treat this person, that would be a reason that a recommending body would say, let's move it up because we're getting too advanced disease at our previous screening age.
Got it. Got it. And any thoughts on why we're getting the more advanced disease in the younger population now?
Because we eat like crap.
Okay.
If we're not
Okay,
eating right, I mean, if we, and I don't, you guys probably have talked about this before in some of these forums, right? But we should be eating fiber. Right? There's all this discussion about all these different micronutrients. Am I getting enough calcium? Am I getting enough, protein and this and that? We need to be eating fiber, 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 fiber. 35 grams of fiber a day is what we should be trying to eat in our diet. I'm not talking about Metamucil, right? In our diet, 35 grams. If you eat 35 grams of fiber in your diet every day, it is going to be very difficult for you to get colon cancer unless you have a genetic disease that gives you a propensity for it. And so what I think is that essentially we just have people eating so poorly that they're getting colon cancer at much earlier ages than before.
It's so very preventable, right? Our number one cancer, colon cancer.
Super preventable. Absolutely. And you don't see it in populations that eat these high amounts of fiber. Colon cancer is a non-existent entity.
This is awesome. Thank you so much again, Dr. Stevens. For anyone that wants to go back over his presentation, just a reminder too, we are going to have the video saved on prevdoc.com, barring any technical issues. So thank you.
You're welcome. Have a good day, you guys. Thanks for having me.
Of course, our pleasure.